And we're live.
Okay, we're live. Back to Senate Appropriations. We have Department of Mental Health, Commissioner Haas, and others. That you'll introduce yourself when you want to. You can do it all now, and then we could introduce ourselves if you don't know the new members.
Great. For the record, Emily Haas, Commissioner for the Department of Mental Health. Go ahead, Shannon.
And I'm Shannon Thompson, the Financial Director for the Department of Mental Health.
And I'm Samantha Sweet, the Deputy Commissioner at Department of Mental Health.
Great. So, Senator Watson, Brennan, we'll start with, go the same way every time.
Same way every time.
Consistency.
Pat Brennan, I represent Grand Isle County and Colchester.
And Andrew Kirkslick, I represent the Washington District, which includes some other towns outside Washington County that we also represent.
Bob Norris, Franklin County, and the town of Elbert in Grand Isle County.
In Washington District. Nice to meet you.
And then we have Senator Lyons, as I'm sure you know, from
We do.
Senator Westman, and then the pro tem Senator Bruce.
Oh.
So those ones that staying from other years, and I think you know them from their work.
Yeah, absolutely. So thank you for having us. For our initial testimony, I thought I'd just start off with an overview of what our system of care looks like, just to sort of ground us in a strong foundation. And then Shannon will go into the ups and downs sheet. So what you have on the screen is what we refer to as our pyramid of the system. And so with the bottom two lines being the focus on our community supports as well as our crisis response programs. And so you'll see across the bottom that we have opportunities for youth and adults to receive services in residential, in group homes. The department has what's called Shelter Plus Care vouchers, which support individuals in independent living and also come with a package of services. And then in the orange, in the smallest writing that we could find, is a host of other services that we see as the foundation of our larger system. So there's your traditional individual and group therapy, your clinical assessments, your consultation, medication, your service planning and coordination. And so basically all of those services that go on in the community for individuals interacting with our system. The next level up is our crisis supports and response. And so as a system, we have crisis beds for adults. We have crisis beds for youth. Those are opportunities for an individual to stay in that level of care overnight. We also have recently opened 6 mental health urgent cares. Those urgent cares are for individuals who need an early intervention, but they do not have overnight stays in our mental health urgent care system. And so we currently operate one in the Northeast Kingdom with Northeast Kingdom Human Services Front Porch. We also have one in the Chittenden County area, collaboration between Howard Center, the University of Vermont Medical Center, Pathways, the Community Health Center. We also have one here in Montpelier called the Access Hub, and in Middlebury with CSAC. And then we have 2 in the south that are with Bennington, with UCS, which is a children's pediatric or psychiatric urgent care for kids. That's also the same in the HCRS area, so Wyndham Center, or not Wyndham Center, the Wyndham County. And then Lamoille also has a mental health urgent care for youth. In addition to those urgent care opportunities, we have done great investment in developing additional crisis capacity with our utilization of 988, which is the National Suicide and Crisis Lifeline, as well as Enhanced Mobile Crisis Response, which is a 24/7 two-person response out into the community where the person is experiencing a mental health or substance use crisis. The next level up is in intensity is your intensive residential and treatment programs. Those are our system for adults and youth who require a longer term stay. They don't need to be in a hospital per se, but they do need some enhanced nursing care, 24/7 staff, and a variety of ancillary services to support their success. The next level of care is our secure residential, otherwise known as River Valley Therapeutic Community. That was and is the replacement facility for the Middlesex facility. I'm gonna go way back. Middlesex came out of Tropical Storm Irene, and that's used to be a 7-bed secure residential, is now 16-bed secure residential in Essex. And then we have our highest level of care, which is our hospital level of care. As a whole, the state has 229 hospital beds, with about 30 of those being targeted towards youth and adolescents. That's what's currently online. There is a pending CON with the Green Mountain Care Board for an adolescent unit at Southwestern Vermont Medical Center, but that's not online. It's still sitting with the CON process. From the adult perspective, we have adult units at UVM. There's 2 units there. There's also 2 units at Rutland Regional Medical Center, with one of those being what we would refer to as a level 1 unit. A level 1 unit, from a language perspective, are typically folks who would have gone to the Vermont State Hospital. So there's typically a higher staff to hospitalized individual ratio. They may need court-ordered meds and such. So beds at Rutland for that group. We also have inpatient beds at the Brattleboro Retreat. Vermont Psychiatric Care Hospital, which is a 25-bed hospital here in Berlin, and then the Wyndham Center.
So that's part of the 142 beds?
The 220, oh yeah, for the level 1 is outside, so 57 level 1 beds. Those are essentially the Vermont State Hospital replacement beds, and then 142 general units.
So the level 1, are those all secure?
Mm-hmm. Yep.
Yes, they're all.
So with the potentiality of the psychiatric unit closing in Central Vermont,
Mm-hmm.
how many? Can you just remind me what level that is?
Yeah, that's a great question.
And then also, how many beds are we potentially losing?
Yeah, that's a great question. So CDMC has a 14-bed unit. They have operated at 8 beds for at least the last year due to psychiatry coverage. And so they will close an additional 8 beds.
Mhm.
So as a whole, 14.
What level would those be at?
Those are your general inpatient adult.
So that 142 will go down by,
It'll go down by 14
because you had the full 14.
That's right.
They could only have
Yeah.
that many.
because they have the capacity to do 14, but from a staffing perspective, they were only running 8.
Hi, I apologize for coming in late, and if you let off with this, but I'm looking at maybe between 500 and 600 total. Is that right?
Oh, from a bed perspective?
Yeah.
Yeah, between bed and vouchers, and if you think about independent living apartment, we would consider, if they have a voucher to support that and a package of service, that's the shelter plus care vouchers. Not necessarily a bed, but we count that as a bed because it's an available voucher.
So my question would be, is this inadequate, this number, and how inadequate? What's the number where the delta?
Yeah, I always love a question about what's the sweet spot for the amount of beds that we need in our system. I think from our perspective, this is multiple levels of care. And so when you think about folks who need a hospital level of care, so they need 24/7 nursing, They meet a, higher medical need, for the care they get, just like you would if you were on a med-surg unit. I think we're probably about to the sweet spot. When I was in, care management prior to the pandemic, there were days we had no one, waiting for placement. And we also had open beds in the system. And so in 2019, that was probably right as we were starting to really recover from Tropical Storm Irene. There's more beds in the system now than there were in 2011, 2012, when the state hospital, was flooded. And I think from that perspective, we're probably at a sweet spot, but I want to say that with a caveat is that a bed isn't necessarily a bed. And so you have units who might have open beds. Somebody may need a bed, but, the unit isn't able to staff that individual, adequately. They could have, not a good relationship with somebody else on the unit, or the milieu isn't, set up for somebody to go into it. And so there are times that there are beds open or people waiting. And that could also be transportation, could delay somebody's admission into a bed. When our lower levels of care are well-staffed, and moving fluidly, you start to see that, relieve your highest needs. And we were seeing that prior to the pandemic, and my hope is we can get back to that. But we've seen an increase in adolescent and youth mental health needs. So that's some of the pending.
And I guess that's my follow-up would be, I'm a little surprised at the answer, because I had understood there to be a greater need than we were prepared to deal with. Is there, one of the tiers that is exceeding, by dramatic amounts, the ability that we have to take care of it? Or do you think each tier is at the sweet spot?
Yeah, great question. And so I think for all of healthcare, when your lower level outpatient system is not stable and providing, the lowest level of care, then your highest levels of care are maxed out and get overutilized. And so, we've targeted, specific levels in the investments the legislature has over the last, since Tropical Storm Irene. And I think as we've shifted to our crisis supports line, and continuing our work at the community mental health line, your foundation of outpatient services makes the need for your highest level of services go down.
But I guess my point is then, the bottom two tiers, you feel like there are enough vouchers, beds, et cetera?
Well, I would not say that.
Okay, what
But
are you saying?
I think that when you have that, when your lowest levels of care are stable, your highest ones are gonna be less
Understood.
utilized, and there's a lot of complexities that go into that. So it's not just about the number of vouchers. If there's no apartments for people to move into, then it doesn't matter how many vouchers we have. And if you have, case management needs and there's a staffing shortage, then you're not getting the services you need, not necessarily because of the positions or the beds, it's because you haven't been able to hire folks into those, open positions to provide the service. So this is the system that we have. It's not fully staffed across the continuum. And so it'd be really tough to answer that, unless it was fully staffed across the continuum and there was adequate places for people to live.
Okay, and then my final question would be, if we're inadequately staffed and we have too few places to live, is there a plan for getting those issues dealt with, say the governor's recommend?
Well, I don't think the governor's recommend is fully out yet. So from a BAA perspective, you're not gonna see any of that in here. That's what we're here to testify about today. I'm happy to come back, at a later date, but we have a housing, issue here across, all departments and state government and our communities. So, I don't have an answer for that today.
Okay, fair enough. I had been thinking of the mental health system as something endemic to it was shortages of various sorts. And so this struck me as and or your presentation of it struck me as very optimistic, and I'm just wondering, are we, maybe in the big bill, are we looking at greater investments in those areas that you mentioned, the staffing? Maybe it's a workforce issue that more money will help, I don't know. Thank you.
And I have to say glass half full in order for us to operate as a department. We can't get too far down that.
Senator Brennan.
Yes, given the situation we're in now with this system,
Mhm.
would it be preferential to, if we were able to go back to a centralized unit such as Waterbury? I know it's cost prohibitive at this point, most likely, but
Yeah,
is there a preference or a?
I mean, I
That's a
think
tough
lots
question
of
for you
people
to
have
answer.
lots of opinions, right?
Right.
For folks to keep in mind though, the hospital in Waterbury would be a general fund hospital.
Right, okay.
And I think that would be very challenging for us to move into that direction. And I would say secondly, Vermont's done a lot of really great work with the institutionalization. And the way that our decentralized system is right now, people are able to get service a little closer to home than they would if it was just in one place in Waterbury. Yeah.
So I'm looking for fodder here to deal with a constituent who is very passionate about that issue. So I think you've given me a little bit of info. Thank you.
Absolutely.
Commissioner, this really focuses on beds, but that's not the only focus of your department,
Correct.
right?
Yep.
So everything else is in that bottom orange box?
Yeah, so when you think about our supports at schools, our supports out in your communities, whether that be.
That would be like the county, like Washington County Mental Health.
Absolutely. Yep, Washington County Mental Health, NCSS, or Northwestern Medicine Service, Orange County, that's Claire Martin Center.
Senator Wilson?
Maybe this is not the time to ask this question, but I'm just thinking about how you all are funded. And I feel like this is going to be something that I probably just need to take offline and talk about, because I imagine that it's complicated.
Yeah, and we'll be back to do a full
Okay.
budget presentation.
Okay.
This is just our budget adjustment. And so you'll get some of that information when we come back at a later date.
I'm gonna put a pin in that.
But that's a good transition,
Right.
if we want
Yeah.
to transition over to the ups and downs. So I'm gonna turn it over to Shannon Thompson.
Okay. I don't know if you can see that, it's pretty, oh, thank you, that's much better.
Yeah.
So,
You can make it bigger, I'd make it.
I'd go for one more. Nope, bigger.
Is this on the website?
It's on the website.
That's not bad.
It's on the website under, prior
Oh,
Samuelson.
okay, thank you.
Cause it's on page 11.
Okay.
I think it was printed out.
It's also printed, yeah.
Oh.
But it looks like the thing in front of Senator Bruce, which is smaller than you could read.
Right, that's okay, I have good eyes.
If you have good eyes, you
Yeah.
can do it. Okay, thank you.
sure, okay.
And you had the joy of being the first person to lead the committee this year to do an ups and downs report. So you might even want to explain the columns and things like that.
Oh, in the ups and downs? Okay,
Yeah.
sure, absolutely. So the way the ups and downs works, the top, row is what our FY '25 appropriation is currently. So all of the things in white are additions or subtractions, additions to or subtractions from. So that brings us to, the bottom line request, of 328,437,139. So it's a $2 million request for VA. So the DMH is funded, with general fund. The first column is general fund. The second column is special funds, and that is primarily billings from our inpatient facility, the Vermont Psychiatric Care Hospital, and the River Valley Therapeutic Residence. We also have, the next column is interdepartmental transfers. That's just a small amount right now, but we have what we call MOUs, or memorandums of understanding, with other departments. So we collaborate with other departments. The next column is federal funds. So we have various federal programs that would fall under that fund source there. And then Medicaid, where there are two Medicaid columns. One is, the first one is Medicaid program dollars. That is like billable services.
That's the Global Commitment Fund, is that?
Global commitment, correct. And then the next column is global commitment investment funds, and we have various investments. 988 is one, our suicide prevention activities are all investments. So that is matched at the same rate as the Medicaid program for the most part. You know, there are certain programs that get enhanced match funding.
You can use the special funds for the match too, or you can only use the general?
So the match is in the
Oh, it's already
Medicaid
in
dollar.
there. Okay.
It's already in there. That's a full,
That's the full.
yes,
The
it's got the federal and the general.
That's the
fund portion.
duplicated fund.
What's that?
Yeah, it's both our match and the federal funds,
Correct. And
separate
those-
from the other federal fund line.
The general fund and federal fund columns are not the same monies as what's in the global
Right.
commitment columns. They're totally separate, different activities. Any
Okay.
questions about that?
Just out of curiosity, what was the interdepartmental transfer? Isn't that, 14,000?
Yeah, that, we typically have more. We ask for excess receipts request every year, but that one in particular probably started with our MOU for Team 2, the Kristen Chandler.
Yeah, Team
Yeah.
2 is a training approach that we utilize with law enforcement and community health workers for response.
And it's a collaboration of Dale, DMH, DCF,
And the Department of Public Safety.
Department of Public Safety.
Shannon, do you want to go through the different line items that we have for talking points?
So the first one is ADS, it's a transfer from AHS Central Office that happens every year for the ADS, the Service Level Agreement. So basically AHS Central Office receives the budget for that and they disperse it to the departments. This is, first one is a redisbursement of those funds. It was, it's just a rebudgeting. There's no overall budget impact to that first line item. The second line item is an actual increase to that same fund source, same line item.
Sure.
Transfer of DCF funded DS waiver children. So this line item, Northwest Counseling Support Services received IFS funding from DCF for the DS waiver kids, developmental service waiver kids. So,
IFS is Integrated Family Services.
yes, thank you. I need to stop that. So it's a net neutral transfer of the funding back to DCF. So they transferred it to us when IFS began in 2014. We are transferring that back to them. They're going to hold the program for that now.
Okay.
The next line item is very similar. This is with the Addison County Parent-Child Center. Again, IFS funding that we received. The Parent-Child Center is actually going back to be under DCF, and they're going to hold that program. So that's just a net neutral transfer of that funding.
And we see these as ups, and they're ups and downs.
Yes, you will see the up in theirs. as well. The Federal Spending Authority, talked about that a little bit with the interdepartmental transfer funds. Basically, we have more federal programs than what we have funding for, so we just need additional funding authority to be able to spend those federal funds. The last one is our PNMI, private non-medical institutions. That's a budget pressure of $1,957,923. So basically, DMH is projecting budget pressure for that due to the utilization and the mix of placements in and out of state for Vermont's most vulnerable youth population. Some of the increase is also due to a rate-setting process that is outlined in the PNMI rules. The rates are set annually for the in-state facilities by the Department of Vermont Health Access. They have a rate-setting division. And they were amended in FY24 to include an annual inflationary adjustment for which we received some funding for. But this is partly that, but it's primarily because of the utilization and the mix of where the children are being served. So I'll let.
Can you give us an example of the PNMI?
Yeah, go ahead, Sam.
Yeah, so PNMI is really a residential, so our most vulnerable kids, usually our most acute kids, need some sort of residential placement, and some we try in-state as much as possible. Sometimes that's not, that doesn't happen, and we have to look out of state, and so.
Well, we could have an in-state PNMI.
Mm-hmm.
We have
Yep.
both. Right?
We have both. So, and so the work happens of getting those kids back into Vermont as quickly as possible, but sometimes they have to go out of state to residential. And so this budget pressure is both because of inflation and the rate setting, and it's also some youth are really acute that we have in the state of Vermont, and they go out of state and sometimes stay there longer than we would like to.
Senator Cruz?
To that point, my memory is vague, but was it the Sununu Center that we used to send to in New Hampshire that closed?
DCF, that would have been led by DCF
Yeah.
versus DMH.
Okay. Because
Yeah.
I know there was some anxiety about being able to find out state placements when they
Yeah.
closed down.
I believe that was specific for youth who've been involved in the juvenile justice.
Yeah.
Ah, okay,
And juvenile justice system for youth sits under DCF.
got it. So this would be a different population, different facilities.
Yeah, so the School for Girls down in Brattleboro would be an example of that, or the NFI homes in the Chittenden County area are examples of the PNMI resource.
We have a couple homes that we use in Massachusetts, so we try to stay as close to Vermont as possible, but yeah.
Thank you.
Yeah.
All right, so that's the changes.
Mhm.
And then what are the turquoise lines supposed to tell us? That's going forward?
The turquoise line?
Yeah, what are those?
That is a compilation of all of the initial budget and all of the additional requests. It's just, so the turquoise line is where there might be ups and downs from the House.
Right, that's like there, as we go, you'll see that legislative changes to the
Correct,
governor's
that might
record.
expand, and you might see certain line items in there.
Right, so it's kind of just a placeholder in the document at this point.
Right.
There's no new information.
Right.
Okay. Thank you. Anything else you want to tell us? Pretty straightforward.
Yeah.
Okay. Committee have any questions about Department of Health? It's your chance. Senator Norris.
I hate to let anybody down.
Yeah.
Came in right at the last second.
So your budget adjustment, decreases is $2.1 million. And you get that from where? In the red categories or?
It's adding up everything in the white?
Adding up everything on the white to include the red numbers.
Yes,
Okay. Okay, that's where I was confused.
yes.
And these are expenses, so kind of the red is money you're,
We are transferring the red over to DCF, so you should see exact offsets.
they're expenses you do not, you no longer have. So they kind of
Correct.
help your bottom line.
We will not have those expenses, nor do we have the money. So it doesn't really help.
Thank you.
Okay, great. Well, thanks for coming.
Yeah,
And we'll look
appreciate it.
forward to
Yeah,
seeing
thank
you
you.
again.
I missed all the good stuff.
You mixed all the good stuff.
Yeah, that'd be good.
It was really good.
Senator Washington.
I know.
very well.
Sorry.
Why not?
You own Thursday.
Oh, we're missing, oh, yeah. There's.
Yeah.
I won't be there.
Thursday.
I won't be there, but other BMA staff will be there.
Yeah.
Okay, well, we'll miss you.
Smiling face.
We'll get you in another time.
I'll be